Good evening, everyone. I'm Dr. Priyanka Verma, Senior Resident Nephrology at All India Institute of Medical Sciences, New Delhi. I'm going to present today's ISN General Club and the general and the general under studies today is the PROTECT trial that studies the sparsentan in patient with IgA nephropathy. It is a pre-specified interim analysis from the randomized double-blind active control trial. It was published in The Lancet on 1st of April 2023. It was a multi-center randomized control trial done by Hispeng et al. And PROTECT Investigator Group. So coming to the brief introduction of the disease, and we all know that IgA nephropathy is most prevalent primary glomerulonephritis worldwide with an all over incidence of about 2.5 per lakh population. Its histologic diagnostic hallmark is dominant or co-dominant IgA meningeal deposits. And the other light microscopic features that can be seen are mesangial and endocapillary hypercellularity associated with segmental sclerosis and tubular atrophy, with some patient having crescents. And the clinical presentation is variable from asymptomatic microscopic hematuria, macroscopic hematuria, nephrotic or nephritic syndrome, and in some cases, rapidly progressing glomerulonephritis. Even though the IgA nephropathy was described 50 years back, still there are 20 to 40% of the patient that they lead to kidney failure within 10 to 20 years. And about 20 years ago, Mrs. Bonnie Snyder et al. On diagnosis of her son as in IgA nephropathy, form a foundation of IgA nephropathy foundation and 14th May, and it is also celebrated as IgA nephropathy awareness day. So coming to the most accepted pathophysiology for IgA nephropathy, there is a formation of galactose deficient IgM molecule from the mucosa associated lymphoid tissue from the terminal ileum that will ultimately lead to the an autoantibody against it and formation of immune complexes. Then they activate the complement and deposition of immune complexes in various compartments of the kidney and ultimately lead to mesangial cell proliferation, inflammation, endocapillary mesangial production, and alteration in the podocyte cytoskeletal with endothelial dysfunction that presents as proteinuria and hematuria, and ultimately with the development of tubulointerstitial fibrosis and progressive decline in kidney function. So, as we have seen that ESKD develops in later stages of IgA nephropathy. So, taking the development of ESKD as an endpoint will lead to progression of will prolong the duration of the trial to assess the efficacy of the treatment available for IgA nephropathy. So, if there are other factors that we can use as a surrogate marker in evaluating the treatment available. So we can see that in studies published in 2007 by Rai Chen et al., they showed that with the progressive increase in proteinuria above 1 gram per day is associated with faster rate of kidney decline and also faster decrease in the survival from kidney failure. And also a study published in 2001 in ERA EDTA, they showed that with reduction of 30% proteinuria at 9 months will ultimately lead to prolongation in delay in the kidney function by 10.7 years. So this only shows that significant proteinuria can be used as a surrogate marker in evaluating the efficacy of a treatment in IgA nephropathy. So as per KDIGO guidelines 2021, the main standard of care for IgA nephropathy is optimizing the supportive care, that is blood pressure management by optimizing RAS blockade along with lifestyle modification. In patient, those after optimization of supportive care even after 3 months still have persistent proteinuria, they are eligible into taking part in a clinical trial. So, ACE inhibitor and ARBs, mainly the RAS blockade, forms the current standard of care. So, is ACE inhibitor ARBs are sufficient, and we need another tools in our box to treat IgA nephropathy. So, we can see that in the one of the largest study that was IgA nephropathy in Stop IgA nephropathy trial. In this, we can see that a running phase of 6 months after optimizing the RAS blockade, 94% of the patient achieve remission in proteinuria, and there's also additional 5% patient achieve complete remission at the end of 3 years of study period. So there was still 2/3 of the patient left with no remission in proteinuria, even optimizing RAS blockade for about more than 6 months. Also, study reported by Bakhtias et al. Showed that about 44.8% of the patient, even optimizing RAS blockade at the end of 6 months, did not have any remission. So this leave a significant portion of the patient with no benefit with even optimizing RAS blockade for about a period of 6 to 9 months. Since then, there is another treatment that is studied for about last 2 decades in IgA nephropathy, is steroid. And the steroid has been used in doses of about zero point 0.8 to 1 mg per kg in various trials and for the duration of about 6 to 9 months. And also in the STOP IgA nephropathy trial and Poggi et al., they also use the IV methylprednisolone pulse. So, two of the largest trials and landmark trials for steroid was STOP IgA and testing. In STOP IgA nephropathy, there was significant clinical remission was seen with addition of immunocorticoid over standard of care with p-value of 0.001. However, it did not lead to translated into the nephroprotection effect, and the p-value for GFR decline was only 0.75. In testing also, in both testing 1 and testing 2, the benefit with oral methylprednisolone was seen. However, there was significant side effect associated with the use of methylprednisolone. Even after reducing the dose, the effect was maintained. However, the side effect was decreased. However, the side effect when comparing to the standard of care was more in the steroid group, including serious side effects requiring hospitalization. So, as per this studies, the steroid has a dual some positive benefit and some negative benefit only. So, and also another point is that what can be the optimal duration of steroid in IgA nephropathy patient, as it is a chronic disease and might require longer duration of therapy. And recurrent use of steroid will lead to more side effect. So to increase the positive benefit and decrease the systemic side effect of steroid, Nefecon came into the light, and in 2022, Nefigard study data was published, and it also showed that use of Nefecon, that is the targeted release of budesonide at the terminal ileum, will significantly reduce the proteinuria. But at the end of 9 months, 27% reduction in proteinuria was seen, and in the 12 month, 48% reduction of proteinuria was seen. Also, benefit in the eGFR, we can see that at the end of 9 months, it was in favor of Nefecon with 3.87 treatment benefit in the GFR. That was also maintained at the end of 12 months. However, another issue with the Nefecon is that it is very costly. It is about 100 times more costly than the systemic steroid. And in this population was mostly done in the whites, and Asian ethnicity was not used. So can it be applied to so it may not be affordable or available to all the sectors of patients in IgA nephropathy. So coming to the role of endothelin and angiotensin in patients of IgA nephropathy and CKD patients, and they mostly endothelin 1 and angiotensin 2 are a potent vasoconstrictor and act in synergy, and as they amplify to increase each other vasoconstrictive effect, and most of the endothelin 1 receptors A, B, and angiotensin receptors are present in all compartments of the kidney, including glomerulus and tubular cells. So they act in tandem and increases the glomerulosclerosis and proteinuria, and proteinuria will further increase the in-depth release of endothelin 1 and angiotensin 2. Ultimately, they will lead to tubular interstitial fibrosis and affecting the vasculature of the kidney and leading to kidney failure in the later event. So, to taking this pathogenesis in the mind, sparsentan was developed. Sparsentan is a non-invasive drug. It is a single molecule having both the action of endothelin and angiotensin 2 receptor antagonists, and it is a highly selective for endothelin A receptor as well as angiotensin 2 subtype 1 receptor. So it is called DIARA, and it is made by Travers Therapeutics and promoted as Filas 3. So by looking at the development of sparsentan, the initial studies that was available is from 2002, and they looked at that the ET antagonist and irbesartan has a similar core structure. So they try to use the similar core structure and attach the endpoints that have both the antagonist effect of endothelin A as well as the angiotensin 2. So initially, mainly it was used as a promising antihypertensive agent, and the earlier studies of phase 1 studies and phase 2 studies that was done in healthy controls and hypertensive patients, the results are not available. Then in 2016, do a trial data was published that was a phase 2 RCT done in FSGS patient with proteinuria of more than 1 gram, and doses of sparsentan in the range of 200, 400, 800 and used with comparing to irbesartan. And at the age of 8 weeks, significant proteinuria reduction was seen with sparsentan. With making this as a base, then the duplex trial was started in FSGS and project trial was started in IgA nephropathy. So by this background, we can see in this chart the till now what are the landmark trials have been done in IgA nephropathy, and the latest one is PROTECT, and in earlier months also MMF gain, that was then mainly in Chinese patients. So we are going to do the methodology of PROTECT trial now. It was an international multi-center randomized double-blind parallel group and active control clinical trial done to evaluate the efficacy and safety of sparsentan 400 mg once daily versus the active control, that is irbesartan 300 mg once daily in adult patient with IgA nephropathy and those who have persistent proteinuria despite receiving maximized treatment with ACE inhibitor and or ARBs. So the biopsy-proven IgA nephropathy in the age group of more than 18 years with 24-hour urine protein excretion rate of more than 1 gram and EGFR more than equal to 30 ml per minute per 1.73 meter square as per the CKD epidemiology collaboration equation and receiving a stable dose of ACE inhibitor or ARBs with maximum tolerated dose and at least half of the maximum labeled dose for at least 12 weeks before the screening and the systolic blood pressure of less than equal to 150 mmHg and diastolic blood pressure is less than equal to 100 mmHg. Patients with secondary IgA nephropathy and IgA vasculitis were excluded and including patients those who have cellular present of more than 25% in biopsy within 6 months of the screening period and patient of CKD due to any additional etiology along with IgA nephropathy and those who received systemic immunosuppression for more than 2 weeks within the 3 months of screening period and patients having major hepatic cerebrovascular or cardiovascular conditions were excluded from the trial. So this is just showing the primary and confirmatory endpoints for whole of the trial and primary efficacy endpoint was changed from baseline to week 36 in urine protein creatinine ratio based on 24-hour urine sample. And the confirmatory efficacy points was the study of change in EGFR over 52 weeks, 104 weeks, and then change in EGFR from baseline to 4 weeks post cessation of randomized trial. The other secondary efficacy endpoint that was taken for the trial was mean change from baseline over the time in selected proteinuria variables based on 24-hour urine samples up to 110 weeks and proportion of patients reaching a confirmed 40% reduction in EGFR, ESKD or death. However, this is an interim analysis. So for interim analysis, the secondary efficacy endpoint that was used was change from baseline urine albumin creatinine ratio based on 24-hour urine samples at week 36. Complete remission that was defined as decrease in proteinuria to less than 300 mg per day and partial remission is decrease in proteinuria to less than 1 gram per day of at least once at any time during trial period. And third was proportional of patients reaching a confirmed 40% reduction in EGFR, kidney failure defined by initiation of renal replacement therapy or sustained reduction of EGFR below 15 ml and all-cause mortality. So the sample size was calculated from data taken from the Leicester IgA nephropathy patient registry and data from the Incar et al. Major data from like standard deviation, dropout rates, and a study effect was taken from this. And so it was found that 280 randomly assigned participant will provide a more than 90% power to test that the true relative treatment effect of sparsentan versus irbesartan on proteinuria is at least 30%. And for the testing EGFR secondary confirmatory endpoint, 380 randomly assigned participant will provide more than 90% power to detect the underlying treatment effect of 2.9 ml per minute per year at the completion of the double-blind trial. And this is just showing the study flow after randomization. Sparsentan will be started at the dose of 200 and irbesartan at 150 and the double blind treatment period will be for a period of 110 weeks. After that 4 weeks there will be a washout period. There no study medication will be given and the standard of care will be resumed that was patient taken before the screening, followed by open label extension with end of study. And the interim analysis will be performed at 36 weeks and confirmatory endpoint will be performed at 52 weeks, 104 weeks, and then 114 weeks. So this is showing the dose titration, how it was done. The sparsentan was initiated at the dose of 200 mg and in the end of 2 weeks, if the patient is tolerating the drug well, then it will be increased to 400 mg. That is the target dose and then the patient will be continued on that. If the patient is tolerating the drug except for asymptomatic hypotension, then 200 mg dose will be continued. And if patient is not tolerating the sparsentan will be discontinued. In the irbesartan group also, the dose irbesartan was started as the initial dose of 150 mg. Patient tolerating will be increased to 300 mg at the end of 2 weeks. Patient tolerating, except for asymptomatic hypotension, the dose that will be continued will be 150 mg only, and patient not tolerating the drug will be discontinued. So coming to the statistical analysis that was used, the all participants, those who received at least one dose of the randomized treatment, will taken as the primary analysis set. And for this interim analysis, primary analysis set is used for all the calculation of statistical analysis. And the analysis will be based on the randomized treatment assignment. That means the participant who received the control group will be studied in that group, and patient who received the drug under target will be included in that group only and analyzed in that group only. Then what is an interim analysis? So interim analysis is pre-specified analysis when trial is undergo. It is mainly one or more planned analysis of the data before the final planned analysis can be published. So it is mostly done to evaluate the probability of study success or maybe failure while controlling the statistical error. So what the examples are like EMPA kidney and testing. So, what is the need of an interim analysis? So, it is an ethical imperative of us to stop or continue a study if the clinical evidence showed that a drug under trial have a significant benefit over the control arm. So, we can analyze it previously, and also it can be stopped. Or if there is significant safety issues with the drug, patients having significant side effects and life threatening, so we should stop the trial to stop the undue exposure of the drug to other participants. And if there is a lack of difference in the control arm and the trial arm, trial drug, so we can stop the trial before to decrease the cost of it, and it is will be futile to continue the drug. And if there is slow accrual, matlab slow enrollment of the patient in the trial, it can also be stopped and depend upon the trial organizer to do that. So the problem with interim analysis, as many number of times we analyze the data, there will be increase in the chances of error in that. So if we are analyzing a data for 3 times and we are analyzing 5 times, then if we are analyzing 5 times, the error will be more. So both the error like alpha error and beta error can be increased. Alpha error, as we are going to use, if we are using 5% of the alpha error in each analysis, so alpha error will be compounding and will be increased more. And beta error, as at every analysis, the sample size will be less in the initial analysis. So power of the study will be lower in the initial analysis also. So to decrease these errors, the multiple method of distributing the error has been shown, like O'Brien, Fleming, Hayward, and Peacock. So in this, as it is an interim analysis, a pre-specified multiple testing procedure was used to control the overall type 1 error at two-sided alpha value of 0.05. And mixed model repeated measure analysis was used to study the primary efficacy endpoint analysis of unit protein creatinine ratio. And then mixed model random coefficient analysis with ANCOVA for assessing change in EGFR from baseline to 4 weeks post-cessation of the randomized treatment was to use to analyze the secondary efficacy endpoints. To assess the proportion of participants with complete and partial remission, logistic regression was used, and descriptive statistics was used to define the proportions of participants reaching a confirmed 40% reduction in the EGFR, kidney failure, and all-cause mortality. And SAS software version 9.4 or later was used for all statistical analysis. Coming to the study flow. So from 20th of December 2018 to 26th of May 2021, about 671 patients were screened for eligibility, and of them 406 were enrolled, and then 406 were randomized. Two of the participants did not took the study drug, so finally 202 patients received irbesartan, and 50 of them has completed treatment, and 105 treatment is ongoing, and 39 discontinued due to various reasons. In sparsentan group, 202 received the sparsentan drug, and 65 have completed treatment. 114 treatment is ongoing, and 23 discontinued due to various reasons. So coming to the results, so at the time of interim efficacy data cutoff, the median duration of treatment was 64.1 week, and about the target dose was achieved in 94% of patients in sparsentan arm and 96% in irbesartan arm. However, 13% of patients in sparsentan arm required dose reduction, and 9% in irbesartan arm required dose reduction. Coming to the baseline characteristic, the mean age was about 47, and 60 to 70% were male in each, and the major race that was included in the trial was about 67% of the white population, and 27 to 30% patient was in Asian population. And when looking at the diagnosis, the age of the mean age at the diagnosis was 40, and time from initial kidney biopsy was about 6.4. That was prolonged. And coming to the history of hypertension was about 70%, and urine protein excretion ratio was 1.8 gram, meaning urine protein excretion ratio in about both arms. Other parameters was also comparable between the two arms. So coming to the how much patient at the time of screening, what is the use of ACE inhibitor in ARB in the study population? So total 168 patients were receiving ACE inhibitor, and that of them 52.4% have the maximum label dose of the same. And in ARB group, 52.2% were taking the ARBs, with 69.7 has the maximum MLD doses, and 24 patients were using both ACE inhibitor and ARB. And when we see it is as per ethnicity, so in Asian geographic group, we can see that the ACE inhibitor was about used in more than 50 to 80%, and well as more than 80%, including more than 40% is 99% were taking more than 90% of ACE inhibitor, and about 99% patients also taking ARBs. In North Asian population also, about 97% patients were taking more than 90%, more than 50% of the maximum level dose of ACE inhibitor, and about 99% patient taking ARBs. That was more than 50% of the maximum level doses. So coming to the result, so in the first diagram, we can see the percentage change of geometric mean least square in the urine protein creatinine ratio was significantly more. That was 49.8% in sparsentan group and only 15.1 in irbesartan group, making it to significant value with p-value of less than 0.001. And the effect was seen at the first trial visit, that was the 4 weeks. We can see there was significant difference in the UPCR reduction with sparsentan at the 4 weeks, and it was maintained at the end of interim analysis trial, that was 36 weeks. Also we can see that the complete remission was achieved more with sparsentan group, that was 21% versus 8%, making odds ratio was 3.1, and partial proteinuria remission was seen the 70% with sparsentan comparing to 44% only with irbesartan, with odds ratio of 4.5. And the similar outcome was also seen with urine albumin creatinine ratio, with 45% reduction with sparsentan versus irbesartan, making the p-value of less than 0.001. And as the data for secondary efficacy and confirmatory points was masked as this interim analysis, so only about 20 patients is the secondary endpoints of decrease in the eGFR, and that was seen in 3% cases. That was 7 patients in sparsentan and 13 patients in irbesartan. But still, we cannot comment upon the nephroprotection part of the drug at this point of time. So coming to the adverse event, the adverse event that was more than 4% between the two arms. The significant one was first peripheral edema was seen maximally, that was 29 versus 19. However, the side effect was more in both the arms. It was a total side effect that was seen was 88% in sparsentan and 78% in the irbesartan group. And followed by hypotension, that including orthostatic hypotension was more in the sparsentan. Dizziness was also seen with more with the sparsentan. And about 21% patient has serious treatment emergent adverse effect in 21% is sparsentan arm and 20% in irbesartan arm. So when seeing the patient who treatment emergent adverse effect that lead to treatment discontinuation in at least 2 or more participants in either group. It was 7% in sparsentan and 5% in irbesartan, basically same, and about 3% discontinued due to AKI, 1 due to renal impairment, and 2 because of the development of CKI, and 2 due to increase in the ALT. So when looking at the changes in the blood parameters, we can see there was not much significant change in mean change in systolic blood pressure and mean blood pressure. However, more diastolic blood pressure decrease was seen in the sparsentan. So as it already established that significant persistence of proteinuria above 1 gram will lead to high risk of renal failure in IgA nephropathy patients. So with sparsentan, there was robust and meaningful reduction in proteinuria was seen. There was 49.8% comparing to 15.2%, and also achieving odds ratio of achieving complete and partial remission was more with sparsentan. As we also that there was not much significant change in the DP reduction with sparsentan arm except for diastolic blood pressure. So the other pathological and hemodynamic effect of endothelin 1 blocker and angiotensin 2 receptor blocker will play into role in its antiproteinuric effect. So coming to discussing the safety point, so we already seen that the most frequent emergent events were peripheral edema, hypotension, and dizziness along with hyperkalemia. Fluid retention was common, however, it was very mild, and it was managed with diuretic, and the use of diuretics was almost similar in both sparsentan and irbesartan arm. And no serious case of heart failure was reported, and body weight change was also similar between the two groups. That was 0.33 kg in sparsentan and 0.69 kg in irbesartan arm. So now, as in the earlier introduction, also I already told about various trials in the immunosuppressive arm. So when we look at the standard of care currently, apart from RAS blockade, the other drug that is in our toolbox is SGLT2 inhibitor. So after coming the DAPA-CKD trial, it was a subgroup analysis that was published in 2021, and they studied about 270 participants of IgA nephropathy, and of them 254 were biopsy confirmed IgA nephropathy. In that term, we also can see that with the use of SGLT2 inhibitor, the composite primary endpoint of reduction of more than EGFR decline, ESKDs, cardiovascular and kidney events were significantly less in patient in which dapagliflozin was used. In overall group also, and in patient biopsy confirmed IgA nephropathy also. So, SGLT2 inhibitor has beneficial nephroprotective role has been found, that was published in 2001 in this DAPA-CKD trial. However, the issue with this trial is that it was not specifically designed to test the role of GLT2 inhibitor in patient with IgA nephropathy, and sample size is also very small, so the estimate of treatment effect is also limited. And about 6% patient did not have kidney biopsy, so they might have IgA nephropathy or they might have any additional disease with that. So it cannot be interpolated in such patient, and GFR data was also not collected after study drug discontinuation. So we cannot say that the reduction in GFR is reversible or not. And also, as the mean the proteinuria in this trial was about 900 mg per gram. So, and also it was done in a CKD patient population. So, effect of DAPA in patient with normal GFR in IgA nephropathy was not investigated in this trial. So now coming to the what other project are in pipeline for sparsentan is one is the open label extension of PROTECT that will use the dapagliflozin along addition to sparsentan, and they will study the safety and efficacy of SGLT2 inhibitor in addition to the sparsentan in IgA nephropathy patient only. And in another trial is sparsentan that will be done in incident IgA nephropathy patient. And EPIC trial is safety and efficacy. They study sparsentan in pediatric patient with selected proteinuric disease. So coming to the limitations of the trial, as it was an interim analysis, and so when it was in a shorter duration of time and less number of patients can be included in there, so long-term efficacy and safety of sparsentan could not be commented at this point of time. And also the RAS blockade, that is ACE inhibitor and ARB blockades, before randomization was taken only 12 weeks. However, we've seen that after randomization and patient in irbesartan group, there was additional 15% reduction in proteinuria. So this duration of 12 weeks is randomization period is running period might not be sufficient. And there are also most of the, as we can see that about 97 to 99% were receiving more than 50% of the maximum label dose, but patient receiving more than 80% of the maximum label dose was less in both the arm, ACE inhibitor and ARBs arm. So they might not be at the maximum doses of RAS blockade that was tolerated, and also the cutoff of maximum tolerated doses in various countries are defined separately. And so, as it was done in patient with proteinuria more than 1 gram, so the finding might not be applied to patient with proteinuria less than 1 gram, as there are other factors of that lead to increased progression of IgA nephropathy apart from proteinuria only. And active control that was used is irbesartan. So, patient was also taking ACE inhibitor before, during the trial, and after the trial. So we cannot say that comparing it with this control will be sufficient to imply that sparsentan is beneficial in IgA nephropathy, and it will be a supportive treatment only. So to conclude, the sparsentan in this interim phase 3 analysis, it is showed statistically significant greater antiproteinuric effect, and also the safety profile was compared with the active control irbesartan. However, it's this antiproteinuric effect will translate into the nephroprotection or not, we cannot comment on this point of time. And the further analysis that will come into the later part of 2023 will show some light on the nephroprotective potential of the sparsentan. So that will be all from my side.
Thank you, Dr. Priyanka. So I think it was a very extensive presentation. There are certainly encouraging results for proteinuria reduction especially considering that it is a non-immunosuppressive therapy with a comparable or a good side effect profile. So I would now like to invite our esteemed panelists to comment on the article and raise the queries, if any. And others can probably put up the questions in the chat box and we'll be taking them up one by one.
Yes, so Professor Sakhuja, please. So your comments on this trial.
Yes. One point which Dr. Priyanka has already made is that the number of patients who have completed this 9-month course of treatment is not very large. So it was 65 patients in the sparsentan group and 58 patients in the irbesartan group. Even though when they started recruitment, the number was much larger. But then not all of those patients have completed this 9-month period, and some have dropped out because of side effects. So the number of patients in each arm is not very large. That's one point. The other thing that I also noticed in this study is that the age of the patients that were included in the two arms, the mean age is around 45 years or so, which is relatively an older age group, because IgA nephropathy can occur even in children, can even occur in younger adults. So, so this is a relatively older age group which they have included in this study. So, what would be the effect in a younger age group? We need to have more data in future. So I think those are the two main comments to begin with. And what we need in future, one, we need to know. Yes, one other comment that I'd like to make is that are the effects of sparsentan specific for IgA nephropathy, or since there is an earlier DUET study in FSGS in which also sparsentan was shown to reduce proteinuria. So is it a drug which can be of benefit in all proteinuric glomerular diseases, or is the effect really specific for IgA nephropathy? That is also a question which needs to be answered in future. And finally, is it worthwhile to combine it with immunosuppressive therapies like methylprednisolone given orally, or the targeted release formulation of budesonide? And will that lead to greater beneficial effects? These are questions which, as yet, we don't have answers to.
Yes, sir. Thank you. And as you rightly said, these are the drawbacks. On the positive side, definitely, I think it's a well-conducted, it's a randomized trial. The scientific methodology is quite robust. It's a multicentric trial, controlled trial. The numbers is one of the drawbacks. The other drawback I thought was that you could have biopsy at any point, remotely. Now that doesn't tell us if you go into, we don't know how much of chronicity is there. I wish some sort of histopathological scoring could have been available, in the two groups, just to make sure that we are comparing apples with apples and not apples with pears. Maybe in one subgroup, the disease was more advanced as compared to, because as we said, IgA is a mixed bag. It can present with proteinuria, chronic kidney disease. It appears, again, the age, as Professor Sakhuja said, 45. IgA is a disease of young adults. So I think I would be more keen on looking at if we have to say that it's a disease which is unique to, it's a treatment which is unique to IgA, I would have selected incident patients, which is what I think is now in the pipeline. Well, that's where we will know whether it's a drug which is specific for IgA.
But so, sir, this study was a randomized trial, so obviously they have taken into account, if you say, the biases in the selection and all those properties that should have been. And to start with, they calculated the power of the study.
That's the strength of the study.
Have more than 390, and they had 400. So obviously, in none of the trial, usually the sum of the patient will drop out in the end. And the difference was significant. So standard of care for the treatment is usually used to give AC inhibitor or ARBs in those patients whom you are not contemplating any sort of immunosuppression or sort of, so they must have taken these things into account. And then the interim analysis is a significant, if you see the difference in the proteinuria or the difference in the complete.
Yeah, no doubt.
That was so. One thing I missed, there are a certain group of the patient which they excluded, like heart failure or the patient with liver dysfunction, or secondly,
all secondary was excluded.
GFR. I mean, did they? I could not collect that point. So was there any, because it's a 3 years, 36 weeks interim analysis. So this is means that they found any difference in eGFR at the end of the interim analysis, or have they published any more outcome at 64 weeks? They have now completed, and I think 150 patients, more than that, they have completed 64 weeks. So do we have any results of those? Priyanka.
Only that is 20 patients, they achieved this secondary endpoint data that was available for 20 patients only. And of them, 3% was for sparsentan and 6% was for in patients with irbesartan. Favoring a bit is sparsentan, but we cannot, at least it is not sufficient outcome to be comment that it will lead to nephroprotection. Also in FSGS, also the duplex study, they have published the first outcome that they showed that proteinuria was decreased. However, the eGFR benefit was not seen. So either it will be seen or not in IgA nephropathy. That will be a major question with IgA nephropathy. As most of the patient, IgA nephropathy has clinical presentation is variable. Some may have proteinuria and some may have ASKD development without proteinuria also. So it might help in some subset of anti-protein patients of IgA nephropathy. However, it might not be generalizable to all the patients of IgA nephropathy.
Okay.
One more question I had: how many of them were on background SGLT2 inhibitors, or were there any, or was that exclusion criteria? I missed that.
Sir, it was not an exclusion criteria. However, all the drugs were stopped before randomization. So, how many patients were on SGLT2 inhibitors? I don't have that.
So SGLT2 was stopped before randomization.
Yes, sir. All the concomitant drug, including ACE inhibitor and ARBs, was stopped, and then patient will randomize.
ACE and ARBs, yes, but what about SGLT2? That
yes, data of that is not available.
Yeah,
however,
yeah.
it
So
was
they
stopped.
haven't mentioned that. ACE or ARBs, I could catch. They had stopped.
One thing was that, sir, they had made multiple global amendments for this. So in the last amendment that was made, they had told that probably SGLT2 inhibitors will be allowed, and there will be a separate subgroup analysis which will be done later. So they had done around 6 global amendments in this trial. The last amendment, this was given. That was one. And probably, I think with regard to question from Jakusha, sir, that the discontinuation was high. The overall discontinuation was very less. The numbers which I think Dr. Priyanka was suggesting was that those who have completed treatment was only 65, but the other 114 were on treatment. The discontinuation was less than 30 or around 20 to 30 in both the arms. So discontinuation was not very high in both the arms.
Yeah, I agree. Discontinuation not very high, but completion of that 9-month period, the number of patients is not that large.
Yes, sir. That I think they have explained that because this being an interim analysis, they just wanted to bring it out before the entire data comes out.
Yeah, that's fine. That's fine.
So interim analysis was done at the end of 36 weeks when the last patient was randomized. So patient who were enrolled earlier, they might have completed the treatment, and the most of the patient was under the treatment. So this is probably related to the overall trial period. So Patient will be more including 65 and treatment ongoing in interim analysis than dropout.
So Arun, if I get you correct, that means there were patients on SGLT2 and we'll have a subsequent paper on that.
Yes, sir. Probably the complete analysis in the end will include those patients because it was allowed later in the trial phase. So
okay, so we don't know how many in each group were on SGLT2.
No, less likely that they used to be there in it at present.
All right, okay.
So I think we do have some questions.
I think there's a comment here that it was an exclusion criteria.
It's an exclusion criteria.
It was an exclusion criteria. Okay.
But it was allowed later in the last amendment. So,
all right. Okay.
So Dr. Kher is also here in the panelist. So Dr. Kher, would you like to make any comments or anything in about this trial or anything?
Hello. Yes, I think SGLT2, as was said, will be allowed when the study is made as an open label study. There is, after 114 weeks, the study is going to be an open label study. And with the sixth amendment, they have allowed that SGLT2 inhibitors, and Priyanka said it, that they will allow it to be used subsequently, and then there will be a final analysis which will be done, I think, after about 130 months or 134 months or something like that. I think I have two comments to make. One, that at this point of time, the eGFR data is not available, and they have not given the eGFR data. So this is an interim analysis only on proteinuria, and you can see that the reduction in proteinuria, whatever happens within 4 weeks. Most of it, 95% of reduction occurs within the first 4 weeks. Subsequent to that, it's a parallel curve to irbesartan almost, which is the control group. And so it's sustained throughout. It remains low throughout the period of 3 years that has been used. So there is a reduction, significant reduction in proteinuria, but whether this will translate into any improvement or reduction in decline in GFR, one doesn't know about it. At least in the previous FSGS study, it wasn't shown that it affected the eGFR. So at this point of time, this is an expensive drug. The cost in US has been FDA approved in February. The cost for 1 month is $10,000. So whether at this point of time, whether this is going to be a clinically relevant drug, at least, so in India at the moment is not available. So if one has to get it, one can obviously import it, but it's going to be an extremely expensive drug. So at this point of time, and the questions which Vinay also raised is it a general kind of, I would guess that looking at the mechanism of action, I don't think it would be specific for IgA nephropathy only, because mechanistically there isn't anything that it says that it is not an immunosuppressive drug. It doesn't do much to that. So I would guess that this is an effect, probably is effective in FSGS in reducing proteinuria. It might be effective in reducing proteinuria and many other. Experimentally, at least that's what it is. An antihypertensive drug and reduces proteinuria like the angiotensin II receptor drugs. That's what at least the animal experiments previously have documented before.
One question for you, Vijay. Currently, since this drug is not available and it's going to be very costly, so would you, for your present patients of IgA nephropathy, would you use oral steroids, or would you go for budesonide, or would you go for MMF? Which of these three would you choose?
At this point of time, if after AS and ARBs, proteinuria continues and there is a deterioration, at the moment, I am more in favor of using low-dose steroids, as shown by testing. Budesonide, Unfortunately, the one which is available in India, although it is claimed to be equivalent to the budesonide used in the Nefecon study, but I don't think in the Nefecon study, that was 16 milligrams of very metered kind of an release, specific release into the distal ileum.
Yeah.
The one which is available in India is released in the duodenum. Now, the drug is supposed to be effective in the pious patches and all that. That's where the drug remains effective. Now, there is no good data on Indian drug which is available to us, except for, I think, a small study done by Dr. Roy Chaudhary from Calcutta, where she showed that there was an effect. Small study, small number of patients. So I am at the moment not really convinced whether the drug that we are getting is really the drug which has been used in efficacy study. So I think I have questions about that, and I don't think the pharmaceutical company which is marketing it has given me any proof at the moment that this is equivalent to the same kind of drug. They use the data that this has been shown to be effective in Nefigard study, but that is a different drug, 16 milligrams, and they have marketed 9 milligrams and 3 milligrams.
9 milligrams.
So I don't know why would you, suddenly why would you change the dosage of the drug? So I don't understand all of this at the moment. Since at the moment, I think MMF has also been shown to be effective in one of the Chinese studies recently.
Yes.
And randomized trial. So that looks promising. So at the moment, but currently I'm using low dose steroids for IgA nephropathy.
Right. Yeah, I think that seems a reasonable approach given the current evidence that we have.
Sir, as per cost benefit purpose, can we compare sparsentan versus ACE inhibitor plus SGLT2 inhibitor?
I think SGLT2 inhibitors would be a good way to look at it. At the moment, I don't know what, if at all, sparsentan ever comes into the country, and I don't know what the cost of sparsentan in our country is going to be. It's going to be in the sort of new drug label for about 10 years. It's been recently approved as a drug. So for 10 years, I don't think any Indian generics will be possible. So I don't think the drug is going to remain very expensive. So unless the benefits in the future trials and the data that comes out shows that this is something remarkable, change in the outcomes of IgA patients, then probably where you might be able to reach a patients who might be able to import the drug and use it for some patients. But I would think an SGLT2 effect along with ACE and ARBs, as well as maybe more data on that. And along with sparsentan, you will have some data on SGLT2 with sparsentan. And then let's see how it comes about. I don't know at this point in time.
We have Professor Agrawal sir also. Sir, your views?
I just want to make two comments. Number one, we in these pharma company sponsored study, if you read the disclaimer, the data analysis and interpretation, all sponsors participated in data interpretation and analysis also. And also even 5 authors were employee of pharma company. And second point I want to make that the open label extension study as is being discussed might give some more idea. Actually, open label study doesn't give any idea of efficacy of the drug. Open label extension is primarily for the safety of the drug. So we don't go with the idea that we get some more information on efficacy when the open label extension is started. And in fact, it is becoming questionable of giving permission from the drug regulator for open label extension study for many of such type of studies.
Yes.
Yes.
I think we have
interesting comment from Christina. Christina states that in duplex trial for FSGS, the initial analysis, which was announced at the end of 2 years, they had a reduction of proteinuria, but the recent results which was announced on the 1st of May by the company Travere Therapeutics, they found that the duplex was a negative trial. So there was a protein curve which plateaued after 4 weeks, and so we may have similar results with IgA nephropathy. Initially, we may find some beneficial effects with sparsentan, but if you extend that trial for some duration, probably we may not have all the beneficial effects seen in the initial part. So that was the comment from Christina.
So if there are any other questions, we can take maybe last.
With regard to that, I guess, though it was considered negative because the primary endpoint was EGFR slope. So EGFR slope did not worsen with sparsentan in the duplex trial. It was only that it did not improve as much as they had wanted. Considering the other trials, what we are having right now, the primary endpoint is proteinuria. It is a good, we consider it as a surrogate endpoint. So probably that is the reason why this drug was approved in IgA, but not in FSGS. Because the primary endpoint was proteinuria and it improved. Whereas there it was EGFR and it did not improve. So I guess it would still be beneficial for the proteinuria part. Probably the EGFR slope will take time for the answers to come up. I think there were a couple of questions on ACARBs also. So I'd like to ask our senior panelists about their use of AC and ARBs, the combination drug, whether it is being used by any of you in your practice.
Yeah,
yes, the combination of ACE and ARBs.
Yes, sir. This trial had around 6% of the patients on combination therapy. So though it is not told in guidelines, it is still being followed by certain practitioners. So do you all follow it? If so, why and how?
I don't use them in combination at all.
Yeah, so I use them in combination in some of the patients who tolerate the, so what obviously I do, I increase the maximum. So most of these patients who do not have hyperkalemia, so the one drug, if usually ARB, till the maximum doses like telmisartan, 80 milligram twice a day, and still if there's a proteinuria and the patient does not have hyperkalemia, then I introduce second drug also, but carefully monitor these. So I have maybe few patients, not a lot of patients, but then we need close monitor and there is some further improvement in proteinuria. So these patients, or usually these patients have GFR, which is good, and hyperkalemia is not there at the baseline. So I found this okay in many of my patients.
So I've used this in children and young adults. I mean, definitely not in the spectrum, the population which was looked at the on-target trial, which was elderly, which was diabetic, even middle age I've not used. But yes, children I've used and young adults I've used prior to on-target, even after on-target in children, and it does give anti-proteinuric, additive anti-proteinuric benefits. But as Shyam rightly pointed out, your potassium levels and EGFR levels, you have to be a bit careful with that. So you need to choose your patients a bit more carefully. And it does reduce additive protein. I mean, there's a meta-analysis also. Several meta-analyses are available. It is only after the on-target trial, then suddenly everything came to a halt. But we need to remember that on-target trial studied a very, very, very different population. Most of them were diabetics. Most of them were heart failure patients. Which may not tolerate this, and it was an arbitrary increase in that by Salim Yusuf. Ran at the end of a period, the dose was doubled, so that's why I have continued to use that.
See, the VA Nephron D trial in diabetics also came to the same conclusion that the two should not be combined.
Right.
See, sir, again, the same point. Diabetic have more tendency for hyperkalemia.
Hyperkalemia, yeah, they do.
And heart failure and precipitous decline in EGFR.
So we have safely, so not, there are few patients who are candidate for those, not all the patients. I would say 5 to 10% at the most. Those who have good GFR do not have hyperkalemia. So this is my personal experience, not a large experience, but I'm using the combination in some of the patients.
Right.
So
one other interesting comment was about the dose of irbesartan and titration. So in this trial, I think only 3 months of dose titration was done. And even the control, supposedly the control arm with irbesartan had a 50% reduction in proteinuria, as commented by Dr. Kishore. So probably would the patients have better proteinuria control even without sparsentan if at all the ARBs were better titrated? So that is a question which probably we'll have to see.
What I know is that the infusion, the ARB was maximally titrated. So, and still, in spite of maximal titration of ARB, they did not achieve the desired decline in proteinuria. More than 50% still persisted to have more than a gram proteinuria. That's the reason, that was the background for starting sparsentan, for running the trial.
No, but I will say that this is a very questionable, is very controversial statement in many drugs in clinical medicine, what is called as maximum tolerable dose. It is so much individual dependent that it's very difficult to control in a clinical trial. If you see the clinical trial of rosuvastatin versus atorvastatin, the many a time once you go deep into the primary data, the atorvastatin was very casually stopped at a much lower dose and saying that the maximum tolerable dose was obtained. So this statement of maximum tolerable dose is very, very catchy. It's very difficult unless somebody is analyzing the primary data and the reason why the lower dose was taken as a maximum tolerable. So tolerability was clearly defined and mentioned in the data.
Yes, sir.
So I think a couple of comments were on the BP control which was achieved, whether they were similar in both the arms. The BP control was similar in, the control achieved was similar in both the arms, with diastolic blood pressure slightly better in the sparsentan arm. So whether this would explain the proteinuria reduction is one of our queries.
So there are some of the questions in chat box. I think you can read them, Arun. Chat box.
Sir, I think
Question and answer.
Some of these questions only, sir.
Yeah.
No, so one of them was from Dr. Arvind Chanchi. We asked that we don't use irbesartan in India. We mainly use losartan and telmisartan. Why do Europeans and Americans prefer irbesartan? Probably, yeah.
Actually, it does not make difference. Ultimately, you have to see the proteinuria reduction and the probably it's a practice we have using it, and many of the earlier studies were done with losartan in diabetes also, and like renal study and all those study, and telmisartan is obviously long acting, so it does not make much difference. Maybe the practice. I see many patients from Nepal, they use a lot of irbesartan. They mainly use irbesartan. Probably the practice there or the availability, that could be a factor.
Yeah, it also depends on marketing by drug companies.
Yes.
Hardly anybody comes to promote irbesartan.
Yes. So that could be a factor.
I think Dr. Arvind Kanche had also asked about the subgroup analysis on Asians who were around 1/3 of the study cohort. I guess one of the forest plots in the supplementary analysis had them, and it showed that between Asians and whites, there was no significant difference in response to sparsentan. Probably because we don't have the biopsy findings, I think differentiating the response based on prognosis or ethnicity may be difficult, and this being a non-immunosuppressive drug also. And a couple of questions were on the cost which would, or cost implications of using such a drug in addition to ACRs, SGLT2 inhibitors, and finerenone, which is probably going to be added in the guidelines. So what is the panel's take on this?
I think Dr. Kher already talked about the cost. It's difficult to speculate on the cost till, until the drug comes out in the Indian market. US figures have already been given. But definitely, as far as the science is concerned, I think it's as was pointed out, it's the methodology is good. They have shown good anti-proteinuric effect, which is still better than a comparator starter. So that way, it still is value addition to the existing knowledge. There's no denying that. Obviously, one would like to wait for further publication of, the follow-up data.
Yeah, final result, I think, and then if we have a data of the eGFR also, because that is the ultimate endpoint, and sometime means how long you should continue the drug. The other day I was seeing this MMF trial. So initial for 1.5 years, the recent Chinese study, they have shown there is a reduction in proteinuria and improvement in GFR. But once they discontinue the drug, after the 3 years more follow-up, the result was same, no difference. So how long you are going to continue a costly drug? And that is another question.
Which makes sense actually, because see, the disease activity is going to disappear. I mean, extrapolating from lupus, after a while, you'll be left with chronicity. So using immunosuppressive drugs beyond a certain point, I don't think there is going to be too much of a difference. And use of these targeting the non-immunological pathways, I think that's where you would get a better value for money and a much safer alternative. That's why the histopathological data is crucial. If you can have some sort of scoring available in the baseline, you know what kind of IgA is being treated, how much of disease activity and how much of disease chronicity was there. So that data, unfortunately, is lacking in the current study.
I think, sir, one of the reason why, the histological staging is there, but it could be a remote staging also. The reason is since they are not using immunological drug, since it's a non-immunological drug, they probably went just with the eGFR and not with the histological staging. Probably if the study was centered around immunological drug, the MESC score would be more given relevance than a eGFR probably. They have stratified the patients according to the GFR, 30 to 60 and more than 60, and as well as the proteinuria. Stratification is done, but yes.
I think sorry.
And someone with crescent more than 25% were excluded. So
they were excluded. Yeah.
Probably, I think the mean duration from biopsy till the time the patient was included in the trial was 6 years. So most of them were old biopsies also, and they were on considerable follow-up. Probably that is another reason why MESC would not have been included. MESC was not very much used during that time period also.
I think we are end of 1 hour. Thank you. I thank all the panelists and all the participants to have joined us today. And I hope we continue the same tradition next month with more enthusiastic participation. I want the panelists to have concluding comments, and we end the discussion after that. So Gulati, yeah.
So I think as far as the trial is concerned, we have just discussed it in breadth. But as far as this initiative is concerned, I think I would like to congratulate the young nephrologist team for it's a great source of learning, and from the comfort of your room, you get to analyze this, and something which was missing. So not only for the postgraduates, I think for each one of us, it's a great learning opportunity.
Sakuja sir, a comment on the presenter, Dr. Priyanka. How was the presentation?
No, I think she did a fairly thorough job. So I think that was quite reasonable. And yes, I think it's a very good initiative that we should carry on further. We should continue with this, certainly. I'm sure all of us, including the students, will benefit from this exercise. So I think we should continue this.
Thank you, sir. Thank you, Dr. Shyam Sansal, sir, for taking up the initiative. Thank you, Arun. Thank you.
Thank you very much, everyone.
Thank you.
Good night.
Thank you.